Okay, hi everyone. It's just turned 6 o'clock, so we'll just give it a few seconds just for some other people to join. Thanks to everyone who put some responses on our Facebook page. That was really good. Some really good thoughts, and I think I said to Nicola, thank you for your input. It's really good. Yeah, don't worry about your level, what kind of course you've done, and as long as you can justify what you've put, that's the main thing. So yeah, really well done. Just having a go really, because these, like I say, these are pretty tough. So yeah. Hey Peter, good to see you again. So welcome back, guys. It's Wednesday, so I'm going to change the format a little bit from last week. So just learning from how it went last week. So I'm not going to give you as much information as I did last Wednesday. I want you to have a bit of a think about things again. So if this is your first day this week, the video for Monday is online, so you can watch that one back and then watch this one as well, and see how they all flow together. So again, if you've watched every one of the webinars, you're going to get bored. But my name's Mike, and I'm the Education Director for Movement Therapy Education and clinic director for movement therapy clinics. We're just getting used to online consultations. It's pretty challenging. Not obviously if you're predominantly hands-on, then it's pretty tough. But the one thing that we're finding is that with everybody that's got a lot of time on their hands now, and the government recommending that they go outside and exercise, people are picking up running injuries. So there's things for us to do and advice that we can give. So with every cloud and all that. So yeah, if you follow us on our clinic pages, Movement Therapy Clinics Harborne on Facebook, we'll be putting some things out to our local community, just doing some advertising for our team really. So if you want to use any of our ideas, then feel free to do that. It's no problem at all. And yeah, and any kind of things that we come up with that we think has worked well for us, then we'll share with you guys too. Okay, so catch up then. So we've looked at a case history. It was a young lad called Billy. We picked out some key points, and well, hopefully, and then we're starting to create a sieve and sift through all the information, what is useful and what is not so useful, and then what do we do. So this is the plan. So Monday was an introduction. Today we're going to have a look at objective assessment planning. So what the heck do we do with Billy, and what are the key things that we've picked out from the case history? And then Friday session, so 6 o'clock on Friday, we'll do our last session, and it will be all about what do we do now. Okay, so and I think some of you have already made up your mind, which is good. So what we can do is we can play through certain scenarios with this. So we go, right, okay, if you didn't have that, then what would you do? And then we can create a bit of a flow chart then. So that would be really good. So remember, there's no right or wrong. There's only hypothesis, and these people don't exist. So don't worry, you're not going to hurt them. So any ideas that you have are really welcome. So anything that you want to put in the Facebook group, as long as it's justified, then that's absolutely fine. Okay, so I talked about the sieve a lot. So sifting through the information on that first appointment, and then that should then lead you to this, and just sharing with you the sieve if you've not seen that before. Then this is the kind of thing that we use in my clinic. So we want to look at the psychosocial aspects of that person's life, and are they contributing towards that person's symptoms at all? And then also the biological reasons why they may have the symptoms that they do. Okay, so is it a muscle tendon problem? Is it a bone problem? And basically you go through each of those checkboxes and you go, right, okay, so Billy smacked his head. What could be wrong with his head? Billy's got a problem down his arms. What could be causing that? And you literally just fill in those boxes. Okay, so hopefully you've been using that format, and it seems like some of you have, so that's really good. So I've just underlined some key things here, and then I'm gonna give you a kind of a little bit of a snippet of some things it could possibly be. And again, with this scenario, that it could be a million things. So, and again, as long as you justify it, it's not a problem. So we've got Billy, who's 16 years of age. So we're going to delve into this in a little bit more detail. So we're at 16. You need to think what kind of conditions will 16-year-old, so that kind of as an adolescent, male adolescent, what kind of things are they susceptible to? So what kind of conditions are they susceptible to? It's a bit of a clue. Okay. He's appeared with his mum to the clinic, which is normal. He appears lanky, and again, not sure if that's very PC, but lanky at 5'9" and 8 stone. So if you look at the BMI of a child, then he falls in the normal category. If you class him as an adult, then he is very much underweight. Okay, so from the kind of way this is written, my thought process is that this kid is pretty tall and he's pretty skinny. Okay, he's got fair skin as well, and he's tall and skinny. So again, what kind of things do those point towards? What kind of conditions might being tall and slight and being fair skinned, what can those things possibly indicate? And you might not know, so it's good because you can have a look and see if you can find out. Yeah, exactly. Yeah. So if you have a look on the BMI charts for kids, then his BMI is okay, low but okay. Yeah. And then if you switch it so that he's 21 years old, he's actually really underweight. Okay. So yeah, that's really good, Peter. Good for picking that up. Okay, so he's got a graze to his right knee and his right forehead, so he's obviously fallen on his right side somehow, and then he's limping into the room, which is obviously not a good sign. Okay, so those are some of the things, kind of delving in a little bit deeper there. Next bit, so he's got neck pain, as well as his bang to the head or injury to the head, and then on the right side of his knee. If you want to, Louise, if you want to put in the chat boxes, or if you want to save it all up and then put it on the Facebook page afterwards, then that's fine too. Okay. So he's got neck pain, bilateral, so both sides, general stiffness in his knees and arms, and at the moment we haven't heard what's happened yet, but we will do in a minute. His right knee is worse. Okay, so that's the first time his right knee has been mentioned, but it is mentioned a few more times in the case. He also has a headache. Okay, fine. So the reason why he might have a headache is because he fell to the ground 5 days ago from his horse. Okay, so now this is starting to make a little bit more sense. It doesn't appear to have lost consciousness, but that doesn't mean that he's not suffering from concussion. Okay, because you don't have to be knocked out. Bear with me a second. I'm just going to share with someone a code they've just messaged me. There we go. All right, bear with me a sec. Just come back again. Okay, yeah. So he was wearing an approved hard hat, but the strap wasn't done up. Okay, so basically he wasn't wearing one. So there's no point in wearing that if you're not going to do it up. And at some point it came off when he fell. Okay, so he's basically fallen off a horse and hit his head. He feels quite stiff all over since the trauma, but his right knee is worse. So that's the second time his right knee has been mentioned in the case. So initial progress. So his mum says that he didn't lose consciousness, but as we've said, that doesn't mean that he's not suffering from concussion, because you can still have concussion without losing consciousness. Although appears very shaken, he has had intermittent headaches since. Okay, so that's a bit of a red flag. That's a bit of a worry if he's been having these headaches and he's hit himself on the head. Okay, so 3 days ago, he reported an increased stiffness in the movement of both arms and legs, and especially knees. Okay, well, 3 days after falling off a horse, then you probably would. Okay. However, he has had right knee pain for the last 3 months. Okay, so this has been going on longer. Yeah, good. Yeah, this has been going on longer than the horse accident. So, what I tend to do with these kind of things, yeah, Peter, that's really good. Post-concussion syndrome, yeah, following the car accident, mild concussion, yeah, good. So he's had repeated potential traumas to the head. So if I just show you this, hopefully you can all see. So just do a bit of a timeline. So in my clinic room, I've got a whiteboard that I can draw on, and I can go through the patient history with them, and I'll draw on the board. So what I'll have, so this is now. Cool. Okay, good. Thanks, Louise. And this was like whenever they were injured. Okay. Or it could be right when they, in fact, let's go for this case, we'll go childhood. So what you then do is kind of plot on here when they've had problems. So it's so 3 months ago, I'll just move that to there. He's had this right knee pain. Okay. And he's got it now, but he's been having it for 3 months. Okay, so we've got this chronological order. If there's anything in the sequence of events that's happened, cumulative effect, or is it something completely new? Okay, because it might be related or it might not. So that might be useful for some of you, having a bit of a timeline of events. Cool. So Louise, thanks. Yeah, so we've got anemia, Lyme disease. So you need to put in why as well. Okay, so why do you think you might have anemia, and why do you think you might have Lyme disease? All right, what in the case makes you think those things? I'm not saying they're wrong, I'm not saying they're right, I'm just what's your justification? Okay, so overall progress. Uh, 3 days ago, he reported pain. No matter what position you get in, it still hurts. Then that's not good. Okay, and it's for no apparent reason as well. So it's not like he fell off a horse. Yeah, he's been having this right knee pain, and he just woke up with it one day and it's not gone away. That's not a good sign. Okay, thanks, Kay. You know, okay, yeah, cool, good. Again, if you want to put your justification in there, Kay, why you think that, that's good. Thank you. So, talking of justification, really good at anatomy. Good at anatomy, sports therapy, osteo, whatever you do, we know our anatomy to the knee and go through everything, but you need to think. Yeah, sorry, Nicola. I think there was a bit of a delay on it for a second there. So yeah, you need to think what is all around the knee. So we've got, is it something to do with the patella? Is it something to do with the fib? Is it something to Let me turn that off. It might be when I connected to that. Bear with me a second. I'll wait for a sec, just in case you can log back in again. Still bad? Okay, cool. Right. Okay, cool. Good. Right. I'll wait there for a bit and then we'll see if it comes back again. It's okay now. Cool. Good. Everyone else all right? Okay, good. Thanks, Natalie. Right. Okay. So I'll not play the anatomy thing just in case that caused it to crash. So when you get someone with symptoms in the knee, the shoulder, wherever it is, okay. Nicola, don't worry. I'll record it. Okay, so that you can watch it back. Okay. So you need to kind of zoom into that area of anatomy and go, right, okay, what could be wrong? So we've got all the bones. Okay, cool. No problem. All the bones, all the ligaments, all the tendons, and that's going through the sieve. Okay, so you go through the sieve for the knee. Yeah. Then what you need to do is think, right, okay, what other things systemically, so blood supply, lymphatic supply, maybe there's some kind of disease that affects the knee, and for that particular age group as well, what else could it be in there? Okay, so that's where we kind of zoom in to that area and then we create our sieve. So from these first bits of case history, yeah, these last few slides here, when you're doing a subjective history with someone, then go through those things and you should immediately be thinking that. Okay, so you should be immediately thinking what kind of things are going to go in my sieve. Yeah, and then because those are the things that form your next question. All right, so a little bit more on this one. So daily pattern, we've got stiffness and heaviness moving his neck. All right, so he's just had a fall from a horse a few days ago and he's got stiffness and heaviness moving his neck. Yeah, he's also got tenderness. Yeah, good. Yeah, well done, Peter. Yeah, so tenderness to touch over the right parietal region and the forehead. Okay, that's not good. Yeah, so if we know his helmet came off as he fell from the horse, and then this knee pain has been worse at night. So he's got constant pain in that knee, and it's giving him night pain. Yeah, and it's for no apparent reason. We've got some problems with that knee going on. Okay, I'm not going to give you any more information than that. I want you to have a look between now and Friday. Associated symptoms, we've got paresthesia in both hands. Yeah, I think someone mentioned thoracic outlet syndrome again. Yeah, possible differential, but we've got it in both hands this time. Yeah, so that's not good. Yeah, if it's on both sides, that's a red flag. And we need to be thinking about some kind of central problem. We'll go through in a minute. Yeah, constant pain, red flag. Yeah, definitely. Well done. If I don't know whether it's Elizabeth or Liz. So Elizabeth will go posh. Okay. So yeah, constant pain, red flag. Yeah, anything where it says constant or that. And this is a really good thing to do with your patients. So if someone says I'm in constant pain, you say, how is it now when they're sitting there? Okay. And if you say, well, it's all right now, it's not constant. All right. Constant pain, constant unremitting pain needs to be there all the time. Yeah. Well done. Wiz. Okay, Wiz. Yes. Yeah. Remember you from Facebook. Yeah. Sorry. Wiz. No problem. Yeah. Torsif. Yeah. Good. So another red flag with night pain. Yeah. So constant pain, night pain, all of those things are not good signs. Yeah. So whenever we hear that, we need to delve into those a little bit deeper. Cool. Okay. So this is another red flag as well. So he's been to the hospital small injuries clinic after the fall from the horse. They've recommended that he come to see you, but he didn't have an x-ray. Yeah. Another immediate referral. They're all immediate referrals, Carl. They're all immediate referrals. Don't deal with them. Send them to someone else. So we've got a 6-month history of intermittent neck pain following a road traffic accident. So if you remember that timeline, we've had the RTA 6 months ago, and then we've had this fall from the horse a few days ago, and he's hit his head again. Okay, so we've got another thing that might be sort of linking into his to his symptoms. And he was hit pretty quick as well. So he was stationary, and the impact was 20 to 30 miles an hour. So that's not good. And then again, in the case history, right knee, constant pain. Okay, so it's come up again. Yeah, so we need to keep an eye out for those things. Past medical history. This was an interesting one. So we've got middle ear infections. And again, just a question out to you guys. Don't have to answer it right now if you want to have a bit of a think. But how would middle ear pathology present? So what kind of problems might you have? Okay, and he's been having this since 9 years of age. Has required antibiotic medicine. So he's been having that for 7 years. Okay, so he's 16 now, and he's had headaches from the age of 4 or 5. But he was born by ventouse delivery. Peter again, been injured and longer increased. Yeah, potentially. Yeah, good. So we don't know. So that could potentially be a problem there. His father has something wrong with his back, but can't quite remember the name of the condition. So you know when you get these people in and say, well, the doctor said something. Yeah, good. Well done, Natalie. Thank you. Ventouse delivery found cause recurring ear infections and headaches. Yeah, really good, Wiz. Well done. You get those people in who may have something in the family history, but can't quite remember the name of the condition. So it'd be interesting to get your thoughts on what you think that might be that the father's had. Ear issues, balance, yeah, okay, which leads us on to the next bit. So Billy was always falling over as a little boy, always fell over his feet, usually a kind of inner ear problem. But a specialist told his mother that there was something wrong with her son's ligaments. Okay, so that's a big clue. So what could have been wrong with his ligaments? He's lanky, okay, so he's 5 foot. What was he? 5'9", 8 stone, I think it was. And the doctors or specialists have said that he's got something wrong with his ligaments, but you can't remember the specifics. Okay, so we've got another thing that's pointing towards some kind of disorder there. Okay, so let's go back to there. Cool. So a little bit more deeper into the case history. And this is what I would do if it's my exam. Yeah, so I'd have the case history out. I get my highlighter and I would do exactly that. I'd highlight all the things that I thought were key points. And then I go back through it again and go, right, okay, why were these? Yeah, good. Yeah, so we might have had a growth spurt. Yeah, really good. And again, that might link in with Osgood Schlatters, which was mentioned a little bit earlier down. So that's good. Yeah, I go through with my highlighter and then I try to then pick out my top 3, which when you look at the Civ, which is one of the files that I've given you to download there, then there may be I would try and work out what my clinical impression would be just on my top 3 for those. Okay, so have a look at this. This is just some things. Okay, I've deliberately not put loads of things on, but I want you, and I've not put why either, because I want you guys to have a think about why. Okay, because that's the most important thing. So it's easy to go, oh, it could be this, it could be that, but you need to justify why you've put what you've put. So thoracic outlet I've got on there. So a central cord compression. So something wrong with the neck, spinal cord. Okay, so why have I put that? Skull and cervical fracture. Why have I put that? Raised intracranial pressure. Again, why have I put that? Maybe a soft tissue restriction at the cervicals and the thoracic spine. So if you've not seen that, shorthand for cervicals is CX. TX is thoracics. Osteosarcoma. Okay, so you need to find out why I think that. What is it? If you've never heard of it, you need to do a bit of research. Patella fracture, connective tissue disorder, soft tissue injury to the knee, and then cervical facet irritation. Okay, so there are some things on there that were similar to the last one, but then we've got some things that are new as well. Okay, so if you want to take a picture of the screen or watch the video back after this, then that's fine. You can get my list, see if you can add to that list. Okay, but the key thing is that you fill in the why section in the middle, and then on Friday we'll go for the next step. Okay, so when we have a look again. So what I'd like you to do now is the question, what could be wrong with his ligaments? So there, and she's go back a couple. There we go. So yeah, there was something wrong with her son's ligaments, and I gave you the clue that it might be to do with his kind of lanky appearance. Okay. So usually put it as well as that. Yeah. So if you want to, if you can use my clinical impression to what I think, add your own in as well. Okay. And then you do put that on the Facebook page. That'd be really good. If you want to do it in this kind of format, this really helps me kind of segment my thoughts and go, right, okay, it could be this is why, this is what I want to do. Could be this is why, this is what I want to do. Okay, so then it starts to make sense of all the information. All right, so just a few things from me there to get you going, and if you've not heard of some of those things, then have a look and see what they are. Okay. So what could be wrong with his ligaments? What in the history points you towards a possible connective tissue disorder? Okay, so again, that's two things for you to have a look at if you've not been thinking along those lines already. I think Sharon on the Facebook page started to go down connective tissue ligamentous disorders. So that was good. And if you could put your thoughts on the Facebook page, if you type in @MTECPD, then it will come up with where to put it. Yeah, good. Thanks, Torsif. If you don't want to post, then send them to me as usual, and then I'll post them on your behalf. Okay. Okay. Yeah. Cool. Yeah. No worries, mate. That's fine. Good. So that's the second installation. All right. That's Billy part 2. And as always, if you need any help from me, you can contact me online. If you want any specific help from me, then I have a lot of availability at the moment. So yeah, if you need any help with anything clinical, any kind of clinical education stuff, then let me know. We do run a movement therapy diploma, which I know a few of you who have attended tonight are on. So thank you for coming in. This will be really good for you guys as a recap on the kind of things that we do. If anybody's interested in any kind of online learning with the courses we do, then let me know. But just give me a shout on Facebook if you need any help with this case. More than happy to help. So I will see you on Friday night at 6 o'clock. We're just about I'm just about to do a pub quiz with my family on Zoom, so that should be interesting with everybody trying to work Zoom. So have a good couple of days, and I'll see you Friday. Cheers, guys.